everyone. We'll just give it one more minute to see if anyone else is able to join us, and we'll get started. Okay. Hi, everyone, and welcome. While people are still coming in, I'll go over some housekeeping items. Please make sure to mute your lines. We will have time for some questions and answers at the end. If you have a question during the presentation, please type it in the chat box on the right-hand side of your screen. Please close any other applications or windows that you're not using to conserve bandwidth. And then this webinar will be recorded and uploaded to our website within the next week. So with that, I'm going to introduce our presenters today. Today we have Doctors Painter, Campbell, and Lightford, who serve as interdisciplinary faculty in the Center of Outpatient Education program at the Lewis Stokes Cleveland VA Medical Center. Doctors Campbell and Lightford previously completed the COE program as learners themselves, and Dr. Painter served as the Associate Director of Psychology. Within their current roles, they specialize in curricular development and have a specific interest in developing innovative curriculum focused on social determinants of health. With that, I'll kick it over to our presenters to start.
Hi, everyone. So this is Tamika Campbell, and so I'll be starting the presentation.
We're working on getting the video working. We're having a little issue because there's a fire alarm going off in the middle of our presentation, so don't mind us. We'll just keep going through the slides.
So what we'll be talking about today is developing and implementing a social determinants of health curriculum in our interprofessional training program. And of course, all during COVID-19. So the objectives for this talk are to explain the process that we use to develop this social determinants of health curriculum, and then to discuss the types of innovation that we needed to adapt it to the COVID-19 restrictions. And then we'll talk to you about some of the lessons learned throughout this process and some of our future directions. Okay. So just to give you a little bit of background about our interprofessional program, this was originally called the Center of Excellence. And that's because it was funded by the Office of Academic Affiliations, which is a department within the VA. And they wanted to address this need to train future healthcare professionals in an interprofessional setting. We all talk about how, as different professions, we need to all work together and collaborate. But what we wanted to do was to get trainees used to doing this while in training so that when they graduated, they would be more likely to participate in this type of education and do more innovative measures like this. So this was a nationally grant-funded project for 9 years. And Cleveland was one of 7 sites to be funded by this initiative. And other sites were like Seattle, San Francisco, Boise, Idaho. And the thing about the curriculum is because it was part of this grant-funded project, this curriculum was kind of standardized across all of the sites. So we did have like some latitude with the curriculum, but it had to fall within these specific domains. And we were all kind of, each site was analyzed yearly on this model. And so within this COE, the types of learners that we have are we have medical residents, so MD learners. We have nurse practitioners, both residents and students. We have pharmacy residents, behavioral medicine residents, social work master's level students. We have nursing bachelor students, and then we have interprofessional faculty that represent all of these areas. Sorry. So where we are now is the grant funding ended, and once the funding ended, our support then came from the Cleveland VA locally. So then we had to change our name. We liked keeping the acronym the same, COE. So that's when we changed to the Center of Outpatient Education. So we had similar goals for our interprofessional education needs, but now we had more flexibility with respect to our curriculum. And the structure of the program is that learners have work in primary care, specialty care clinics throughout the week. And then on Friday mornings, we have what we call an academic half day. And within the clinics, when they're working, they all working together in the primary care clinic. So you have the pharmacy residents that are working with the nurse practitioner and MD residents, as well as our psychology residents. And so they all interact together for that professional learning model. And one of the things that we have to always consider is all the learners have different sort of tracks. So the nurse practitioner, psychology, social work, nursing, and pharmacy residents all come to the COE program for one longitudinal year, while the MD residents, through the 3 years of their residency, they come to COE for 3-month alternating blocks. So they'll 3 months in inpatient, then they come to us for 3 months to make sure that they also get that time in primary care where they can follow up and really feel like they're taking care of their patients. And all of this is possible too because our program does have an ACGME waiver, which allowed us to have a lot of flexibility with our curriculum. So when we were able to get this flexibility because of the change in funding, we, as a group, interprofessional faculty came together and we kind of looked at our whole curriculum and what the learners were getting and decided to come up with several new domains, one of which was social determinants of health. Before, we didn't have any formal curriculum, and we did have a few lectures here and there that we felt did sort of encompass some of these ideas, like our social justice lecture. We also had a climate change and health activity, but there was no full structured lecture series. And so that's what led us to start the development of this. And then when we're talking about developing a social determinants of health curriculum, you're always like, well, why is it important? And this goes back to the fact that a lot of people aren't aware of a lot of the social determinants themselves, and then they're not aware about how this actually affects patient care. And there's a lot of research out there that shows that the medical training that particularly medical residents get does not at all address this, but then once they do get this type of curriculum, they're able to better incorporate the learning about these disparities to give their patients more equitable care. And then also, they've shown that many providers who are out of training also are unaware of the disparities either within their own communities or nationally. And once you involve them in this type of curriculum, it also improves the community and individual health of their patients. So this is really important to cover. So when we're talking about developing a curriculum, we really wanted to make sure that it was well done and a well-rounded curriculum. So we actually did a lot of research into how we should develop new curriculum. And we found that when you try to tackle something like this, there are several things that it has to have. One is like goals and objectives. We have to think about how to schedule these events, within that 4-hour academic half day. What resources will we need? And then how will we know that this actually that the learners learn what we intended for them to know at the end of this curriculum? So we came together with a team, and of course it was interprofessional. We had psychology, medicine, and social work, all the involved in this. And so all 3 of us there, and then 2 of our colleagues could not be here today. They were also involved in this team. And having an interprofessional team is really important because then you have people at the table who can bring up different aspects that you might not otherwise get. And then you having people at different levels. So some of us were closer to residency, so we could remember things that we did learn or did not learn, and we could bring that also to the table. So we outlined this in 5 steps in which we came together with our interprofessional faculty. And as a group for each of these domains, we went through all of these steps together. And that was coming up with a vision statement, outlining the objectives of the curriculum for each domain, then going on to develop the lectures and activities, implementing those lectures and activities, and then determining how do we want to get the feedback from the learners to know that this curriculum was successful. All right, and I'll pass it off to Dr. Lightford.
Okay, and our camera is still not working, so just we are being flexible and adaptable to this and this new learning environment. So we wanted to now dive into the actual steps that we took and that we want you all to think about as you go through creating your own curriculum. So first thing is to think of a vision statement for your curriculum. So this is the time where with your group you are thinking broadly about what's important, what's the purpose of what you want the learners to get out of the curriculum. And so a good vision statement is going to be a 2 to 4 sentence statement. It's going to clearly outline what is important, what's the purpose of what you're trying to get the learners to, what knowledge you're trying to get the learners to obtain. You want to make sure that the vision statement can clearly convey everything that you feel that people should know, but then also that it clearly conveys how relevant this is to clinical practice. So of course we want to make sure that anything we teach is impactful to our patients, that it's going to improve their health outcomes. So as you're thinking about creating your vision statement, these are a few things that you want to keep in mind. So as you continue to develop it, the vision statement, you are really keeping the end goal in mind, as in you're keeping the graduate in mind. So what should the residents or students learn? What are key topics that should be covered? At this point, you're not necessarily thinking of actual lecture content. That'll come later, but you're thinking broadly as to, okay, what can we develop within this frame that would be important to cover? And that's under the vision statement, which again, we really encourage you to take time to put thoughtful effort into creating your vision statement first before you continue on with the next stage of the process. So for a more visual representation, on the left is, these are your new learners. So maybe these are your interns, for example. They're coming in, they're bright-eyed, they're fresh, they're eager to learn, and they're willing to soak up any knowledge you have to offer. And then on the right is the graduate from your curriculum. So the arrow that separates the 2 learners, that is your curriculum. So this is what you're thinking of as you're creating your vision statement. The graduate on the right, you want them to feel empowered. You want them to have taken away whatever topic it is that you chose to. And so keeping the graduate in mind as you develop your vision statement will really help you hone in on what's important. So we included a few things. This was for our group. We really wanted our graduates to, at the end, be advocates for their patients, for themselves, for advocates in society. We wanted to make sure that the graduate that we envisioned, that they truly understood how these various factors affect their patient's health. They had a better understanding of health policy and the ramifications of that, and then really understanding how their patient lives in the community that they're in. So this is sort of the pictorial representation of what we kept in mind as we developed our vision statement. So what our vision statement that we made was to understand the interconnectedness of societal and cultural influences on the patient's interactions with the medical community, create awareness of how health policy, legal precedent, societal challenges, and environmental factors affect clinical decision making. And again, the importance is that this is broad enough to encompass everything that we felt was really, really important in this curriculum. So once you have created a vision statement, and again, a broad enough vision statement, you want to then start to hone in on what objectives you will have for this curriculum. So you really want to take time to carefully consider what you, I can speak up. Someone just mentioned they can't hear me, so I'll speak a little louder. Please let me know if this volume is better. Oh, can you hear me at this volume? If someone could just put it in the chat.
I can hear you fine. Is everyone else okay?
There was just someone who mentioned they couldn't hear me well, but I will, yes, but not clear. Okay. I will stand a little bit closer to the mic. Oh. Okay, so much better. Okay, great. All right. So what I was saying is that once you have developed your vision statement, then the next thing is to start to consider what are the objectives of your curriculum. So in terms of objectives, these are still fairly broad, but you're starting to hone in a little bit more on what you feel is important. So for example, as with anything, who is your audience? So you know your group of learners well. Are they, how familiar are they with any of the topics you may have in mind? What are the needs of your patients? What's the community that your patients live in? For example, if you are located in an area that has a vast food desert, do you think that this is something that your learners already know? Do you think that it's something that's important for you to include in your curriculum? We know that having more knowledge of that, of course, will help the learners as they're speaking with their patients and give them a better understanding of what challenges their patients may face. But if this is something that's unique to your area, then it may be something you want to include in your curriculum. And then local policies and infrastructure, these are things that affect affect the patients. But again, it may be something the learners don't know. So for example, in Cleveland, and this is not unique to Cleveland, but it's an issue in our area, we have areas around our hospital where there is not internet access for patients. There may be only one internet provider or no options. And so obviously this has become a challenge with us having virtual visits, and for us, that was something important to convey to our learners. They may not know, they may have the expectation that they can do virtual visits with their patients, but really their patients may not have Wi-Fi options in their area. So those are just a few examples of things you would consider that are unique to your community as you create objectives. And I'm going to hand it over to Dr. Campbell again, just to talk about Bloom's taxonomy.
So I love Bloom's taxonomy, that's why I'm speaking about it. Anytime it is time to develop objectives, I kind of bring out this chart, and I have several different versions of the chart. So if you just Google it, you can find the version that works best for you. And I think it's really important when you're coming up with your objectives to kind of figure out what level on this pyramid that you're trying to convey with your objective, right? So starting from the bottom is the simplest of objectives. So when you're asking people to just know basic concepts and facts, you're going to start at that level. And you're going to use words like define, list, memorize. But then as you go up the pyramid, then it becomes more intricate and more involved with the learner, what you want them to take away from it. So anytime that I'm looking at anyone else's objectives, I'm also judging it based on this, because this also lets the learner know exactly what it is you expect them to do. When you see objectives that say things like remember or state, and all of them say that, then you're really expecting the learner to come away with surface level knowledge, and that might not actually be your true intent. So I am a strong proponent of using Bloom's taxonomy. I'll hand it back over to Dr. Lightfoot.
So these were the objectives that we came up with, again, using what we've already discussed. So our 5 objectives for our overall curriculum are define SDH and explain how these factors affect health utilization and outcomes, understand the complexity of the patient context, hospital context, and societal context, develop strategies to recognize gaps in care, utilize appropriate resources to address individual patient needs, and recognize personal bias and impact on patients. Once we came up with our learning objectives, that is when now you are becoming really specific and getting into, you have your vision statement, you have your objectives, now what lectures and activities will you develop from there? The goal is to prioritize lectures that are relevant to where your learners currently are, and then also very relevant to what's going on in the world. So COVID-19, are there natural disasters? Is there an opportunity, for the example of natural disasters, is there an opportunity to understand health outcomes related to wildfires or flooding or whatever it may be, but anything that will be relevant to where they are currently, but also their community will help them to better implement, the takeaways from each lecture or activity. And then, as always, again, with your audience, you want to know, are the learners more engaged when it's a small group discussion versus self-directed learning? Are they getting more out of the sessions if they have pre-work that they need to do or post-work? So you really want to pay attention as you're developing your lectures, pay attention to what are critical community-specific issues, what are issues that the learners may be facing as they're going through their clinical rotations or in their clinical environment. And so those are the things to keep in mind as you develop your lectures. And with that, so we did all of that work, and then we had COVID-19 happen, and we had to learn how to pivot and adapt as we are doing with this lecture right now. So I will hand it over to Dr. Painter for the next part.
You'd almost think we planned it this way to have the technology not quite work. So my name's Elizabeth Painter. I'm a clinical health psychologist here at PI. And as Dr. Lightford was saying, we have those moments where things are just going so well, what could possibly go wrong? Oh yes, a pandemic. So I say that because at the time of the COVID-19 restrictions being rolled out, I was serving as the interim director of the COE. Our current leader unfortunately had some health issues, and so I had kind of stepped into that role to the best of my ability to keep the ship afloat while she was gone. And let me set the stage for you, because I distinctly remember where I was sitting when it happened. We typically have that academic half day, which means that we have about 30 learners and staff coming in on Friday mornings for our didactics. And it's sort of like the Postal Service. Snow, rain, shine, doesn't matter. These suckers go on. We always have didactics. And it was a Thursday evening, and I got the email that said, oh, just kidding. Starting tomorrow, everything has to be virtual. And I should preface this by saying, within the psychology department, our administrative assistant will often take papers out of my hands and fax them for me in fear that I will break the copy machine. Technology is not my forte, but we were faced quickly with having to make some decisions and pivot all of our learning on a dime to figure out what to do next. And so what we elected to do was we actually canceled one day of didactics. My team stepped up and we made about 1,000 phone calls that night, canceled didactics for the next day, and then had a 4-hour session of figuring out what we could transition, how we could transition it, what might work, what might not work, and brainstorm. So kind of the first idea was, or the first thing that we considered was, what platform do we do this on? We've done a little bit of all of these, but really started with phone and Adobe Connect. So as you can imagine, phone didactics with over 30 people on a phone call was very challenging. Discussions are difficult. Anyone who's ever been on a phone meeting with about 3 people knows that everyone talks at exactly the same time. And it certainly reduces engagement in some ways. But the bonus is, of course, everybody has a phone, and at least we could get a hold of people when we needed them. So that wasn't going to be ideal, but it served as a backup for us. And at times when we were using other platforms, people would still call in. We considered pre-recorded lectures. We've done this for a couple. It's a little bit easier to coordinate, obviously, if you have a library of lectures that you can pull from. You can potentially reuse them. You can have people watch them at different times. So there's some utility in that, but it really took away from our learning, we felt, if you couldn't have that question and answer or those active discussions that went with it. We find our learners often have a host of different patient-specific or topic-specific questions that they really want to talk about in the context of their learning. So what we started with was actually using Adobe Connect. It offers a pretty decent presentation platform. So you can put your slides up, everyone can see them. There's a lot of academic capabilities because that's what it's designed to do. Now, for someone who's not allowed to use the copy machine, it was a little tricky for me, I will admit. We actually had to have one of our tech gurus sort of sit with us every time we had one of these sessions to make sure that we were able to navigate all of the pieces. It also limited the amount of videos that you could have on. So sometimes you could see the slides, but you couldn't see the presenter and you couldn't see the other people if there was a discussion going on, which I really think limited the interactivity. And so people were more inclined to use the chat box, which is fine, but during a discussion-based session, we wanted to have the audio options. So we ultimately ended up with our best friend, Zoom. In part, it's user-friendly and nearly every one of our learners already had Zoom or used Zoom regularly. Now it requires a professional account, so several of our faculty have co-appointments with Case Western's medical school or other places where they had professional accounts, which would let us use longer amounts of time and also have more people in those sessions. So that worked pretty well. We could just set up a Zoom for the whole morning and people could come in and out as they needed to. This also gave us really good video capabilities in terms of, the Brady Bunch style where you can see everybody's faces. If we were having a discussion-based session, everyone could see everyone else. It's not perfect. It's not the same as sitting in the room with somebody, but at least you had some social cues as compared to just doing it on the phone or trying to guess what other people were thinking or doing. So then, once we found the platform, like I said, we started with Adobe Connect, fairly quickly transitioned over to Zoom once we realized that we could use breakout groups and do different things. So then we had to figure out, were there sessions that wouldn't work for virtual learning? And were there things that we should prioritize because they were a better fit? So this took us back to looking at the objectives of our different domains and the objectives of certain lectures to see what we could most easily transition. Now, as you can imagine, straight up didactic lectures were the easiest thing because that's just one person kind of talking, answer some questions at the end. The problem being, I think, sometimes, as you may have noticed when you've been teaching or speaking, or maybe the case right now, I can't see you, people's eyes may be glazing over, people may not be paying that much attention, that the more interactive we could make it, we felt that would be better, but we had to be a little creative with that. So what we tried to do was, as faculty, sort of set the tone that people would be talking and participating and being as active in the education as possible. Then we did some things, some icebreakers, some active sessions. I never in my life thought that I would say, oh, to start this session today, we're going to do a quick TikTok video. But those words came out of my mouth, right? Because it was something that was very culturally relevant at the time. And we used an activity to sort of break the ice and get people talking. We also had the option in Zoom to do breakout rooms. So we could still do small group work, which we found there's a lot of utility in doing some larger group and then breaking them into smaller groups so that everybody has the opportunity to participate with.
We had a question about how did you use TikTok?
Oh, sure. Claire, if you don't mind me just going ahead and answering that real quick. I know we were going to hold some questions. What's your preference?
That's completely fine.
Okay. So we actually did a TikTok activity that was based on privilege. And so it had different people, you put 10 fingers up, and as people describe scenarios that happened to them, like somebody got off an elevator because they were afraid to stand next to me, or people have followed me around in the store because they thought I was going to steal something, a host of different things. People would put a finger down as it happened to them, and then we had a discussion based on privilege because of that activity. So we've used things like that because we found there's actually a fair amount of different kind of SDH sort of themed videos and stuff like that that we could find. But it got the conversation started, and I find on these virtual platforms, once people start talking, they get comfortable with it pretty quick, but you have to get that through that initial period where people are just staring at you or refusing to turn their cameras on, which we'll get to in just a minute. So we talked a little bit about the breakout rooms and still being able to do small group activities. I think that's a really important piece or an opportunity to have so that everyone gets to participate and kind of focus on the specialty they bring, particularly in the context of our group, which is interprofessional. So we could make sure that our breakout rooms had representatives from all the different disciplines in each small group so that they could then work through our case examples or the activities together. And the other thing is we thought the more relevant we can make the learning. I mean, this is probably also always true, but particularly now when we're trying to engage people in this whole new paradigm when the whole world feels crazy, we wanted to make as many things relevant in terms of current events, community concerns, things that are directly related to our learners or to their patients. So this certainly made us think about how we were going to present broadly. Right? So I like the phrase netiquette. So the idea of what the code of behaviors is when you're doing online learning, virtual visits, all of those kind of things. I really considered taking a host of pictures. Dr. Campbell and I were talking about of all the things that you could do horribly wrong, but we elected to spare you that. But the rules feel a little bit different. You know, I've never really thought about having appropriate lighting in my office or things that I have to worry about in terms of setting it up. What can people see behind me on the computer? What's happening there? Or the age-old question of, is there an office open that has a working camera? Does somebody have a mic I can use? You know, all of the things that I always just knew when it was time for didactics, I went to the conference room. So this made those kinds of things more complex and took some problem solving on the front end. The other thing I noticed, and I still struggle with, is I really want to look at the pictures of the people I'm speaking to. So if your video is up, I'm going to look at you like I'm actually looking in your eyes. But that often means I'm not looking at the camera. So it looks like I'm looking off into the distance. I found this to be particularly true with patient encounters, but also when you're teaching, how you can engage folks in a way that's meaningful. And again, just this idea of thinking about how you might engage an audience when you don't have the social cues that you're used to. I can see if I'm giving a lecture and my learners are rolling their eyes at me that maybe we need to take a little turn. But if I don't have that feedback, I might keep going in a way that's not as effective. So we recognize there were a lot of challenges for the learners, particularly right off the bat. I think the learners probably had a little more idea than I did in terms of how to use the technology, but I think this was a whole new world for everybody. We were all sort of headed this way. I wasn't naive. We knew that there was going to be a transition to virtual care at some point, or virtual learning, but I don't think anybody anticipated it was going to happen quite as quickly and abruptly as it did. So when we first started, we had a lot of interactions with learners who were like, oh, I can't participate. Camera doesn't work today, or, you know, my audio doesn't quite work. I guess I can't have that discussion, or those kinds of things. We also found that people were a little more resistant to engage in discussion right off the bat, like I mentioned, on video chats. They sometimes were more okay with using the chat box, but I got the sense that now that's in print somewhere, so people were a little hesitant to put down their thoughts or their feelings, particularly if they had a view that maybe didn't agree with everyone else's. And then there's always the IT issues. The slides won't load, nothing's advancing. Perhaps maybe your camera isn't working, which for the record, had I known this, I would have worn scrubs today. So just want to note my displeasure with that piece. So once we figured out the platforms, We worked out some of the kinks. We really wanted to think about, within this curriculum, what sessions could we effectively do? So we had a subset of sessions that we converted to virtual that we had done in person before, and then we had sessions that we needed to develop that could be done virtually. So in terms of our converted sessions, we had done 2 lectures that we had done before in person, one of which was the history of healthcare. We found that many of our learners say they may have learned parts of this in their graduate training, but they don't remember it, or they don't understand exactly how it impacts them today or how it impacts their patients. So we tried to do that in a way that was very context heavy in terms of how our system developed and how that's impacting us right now. We've done the social justice lecture, which was focused on the involvement of the legal justice system and health outcomes and all of the social determinants of health that impact people being involved in the justice system and also their transition back out to civilian life. So those 2 were slightly more lecture-based, so those were fairly easy to convert. At the time COVID hit, we were also developing a community mapping activity, which was very interactive and involved a lot of small group work, and we were having our learners compare 2 different parts of Cleveland, the resources available there, the challenges and the benefits of being in different areas and what they might have available to them, and how that might impact their treatment planning and their healthcare outcomes. We had a really great plan for how to do it in person, and then really had to think carefully about how to do that virtually. So we were ultimately able to make all of the activities web-based or web search-based, like looking at maps and doing those kinds of things, and using small groups. We're able to achieve what we were going for, but it looked completely different than how we had originally envisioned it. Then we also developed a few brand new sessions. We had talked for a long time about doing a session on advocacy. Broadly, we find that professional groups often aren't their best advocates, though they have a lot of opportunity. So we wanted to talk about the different ways our learners could participate in professional advocacy. And we actually gave them an opportunity to learn about and then practice writing op-eds. And then the last 2 talks or activities that we did were very specifically based on the current climate. We had a process session related to COVID-19, where we were finding that this had huge impacts on the learners, both in and out of work, because many of our learners were coming off the inpatient COVID units, their families, their communities, and also the interactions they were having with their patients. So we wanted to make the space for that and also give them some tips and tricks on how to manage for themselves and for their practice. And then we also had a talk or an activity based on racial injustice, which occurred shortly after the murder of George Floyd. We recognized that our learners didn't really have a space to process this, to ask questions, to talk about it. And so we developed an interactive session for that based on processing these pieces and also managing mistreatment for them at work. All right. And I'm going to let Tamika talk a little bit about how we were addressing feedback, because obviously we come from kind of a quality improvement sort of background and want to make sure that we are working towards the best curriculum that we can have.
And so anytime you're developing any activity, I always encourage people to think about this process as well. It's like, how are you going to get feedback? How will you know that you got the outcome that you wanted? Maybe you felt like the lecture was really clear and the objectives were very clear, but your learners came up with something different or felt like there were things missing from the curriculum or from a lecture. So, verbal feedback the best. And, when you have like smaller groups, I think verbal feedback works really well. But that also you have to create a safe space. So, in our curriculum, when we do verbal feedback, faculty is not present so that the learners really can feel like they are able to really express how they felt without the lecturer or any other faculty members present. Surveys. Coming out of residency a few years ago, I'll tell you the number of surveys that we received were insane. And so you get that people don't want to do them, right? And once you start giving them, and even when you change them into a virtual, because there's so many different survey websites and apps you can use, but you still get that same drain and fatigue. Then when you want, because the best feedback is what I find is qualitative feedback. So then when you're trying to get these short forms, who's actually going to be the person who responds to them? A lot of times you only get a few responses because those are the people who felt either strongly positive or strongly negative towards the activity. So you have to think about that, and when you're processing all of this feedback, keep those sort of things in mind. And then again, like the survey and virtual fatigue. Because what we found was the lectures that were presented at 8 and 9 a.m. typically got more surveys returned than the ones at 10 and 11 a.m. because by that point, the learners were done. They're like, I already did 2 or 3 of these. I'm not going to do another one. And so you would definitely see that declining number just based on that. So, for example, for our demo with the social determinants of health, like I said, we got both real-time feedback after each lecture or activity with the chief resident of the COE program, and then we have the short minute papers. Our minute papers were 3 of the 5-point Likert scale questions where we asked about how useful the learners found the lecture, what was their confidence level in being able to use the information gained from the lecture after it was presented, and then what was the overall quality of the presentation. And then the last 3 questions were short answers, like was there anything that we could have improved about the lecture? Were there any questions that you had that were not answered by the lecture? And then what were the major take-homes for you? We felt like this was very short form, but then gave us a lot of both quantitative and qualitative data that we can use to improve the lecture series. And so this is an example from the racial injustice lecture. So, you know, overall, we had a small N of the number of surveys we got for feedback. But again, this was the last lecture of the day. And also, this was a lecture where I think a lot of the learners kind of logged off and processed this because it was kind of emotional. And it might have just been that was not the right time for a survey. So we also have to consider things like that.
We ultimately got more information about this session from verbal feedback once we went back to have that discussion, which was useful.
So you see at the top, overall, you know, we have somebody rated it very good. One person gave it a 4, one gave it a 3. And then for the suggestion for improvement, they wanted more tools for learning how to be anti-racist in the workplace. They felt like it was more geared towards physicians, combating these sort of things from patients, and they wanted more accountability on how to acknowledge their own prejudice and insensitivity. And then, you know, the comments, people said they were excellent. They would like for us to get delivered in other settings as well. And then the same person about the anti-racism in the workplace.
And I think that was interesting because that feedback actually helped us recognize that we did a lot in an hour. We felt like it was so important that I think we probably pushed too much together. And so in the future, we're considering kind of breaking those into 2 different pieces so that we can do kind of managing that mistreatment and also a racial process group and make sure that we hit on all those things, but give people the space they need, which that data was really helpful because I often feel like all of the lecture should be about the things that I think are the most important. But realistically, we want to make sure we have a finger on the pulse of what our learners think is important as well. So we learned a number of lessons in this process. One was we try and give ourselves a little grace, and we try and remind our colleagues of that too. It's a pandemic. We're all trying. We're all working hard. And I found that the learners are pretty forgiving in terms of our transition, and so are the staff. And so we're working together, and I think everybody's on the same page with that, which I really appreciate. One of the things I learned quickly was the importance of requiring a camera and audio for every single session. Setting those expectations early, because I found that many of the learners would use oh, my audio doesn't work, oh, my camera doesn't work. By this point in the pandemic and in our virtual process, everyone's using camera and audio for a host of different things. That's how you're talking to your family, that's how you're seeing your patients. Everyone has that technology, so it's the expectation that you will participate fully in all of the sessions. In the same way, you want to model success with the medium, and also have a moment where you're okay with sitting with them in silence, because I think we often at the beginning of sessions will try and demonstrate some discussion amongst us to make sure everybody's clear that it isn't just a lecture, that we want participation, but also that if you just sit quietly, I'm not going to let you be done earlier. We're just going to sit here and then we're going to figure it out. So really working through what this is going to look like, and helping people recognize that these sessions are actually probably more fun and more engaging if you participate actively. Historically, when we were presenting in person, we would often start discussions or answer questions as we went, so you didn't have to think much about it. Now we're much more purposeful in adding brainstorming or discussions or those kinds of things throughout. We put them in the slides and sort of indicate to everyone, this is what we're doing, and we're doing it purposefully right now. So everyone has a clear expectation of, this is a time that we want everybody to participate, and let's engage. I'm always a silver lining kind of person. So one thing I think this offered to us was that we had more experts, more speakers, more faculty that we've been trying to get involved that have had scheduling issues or problems getting to the hospital when we're doing didactics, and having the option to do these didactics virtually and engage them that way has actually gotten more people involved with our curriculum, which is pretty exciting, and I'm hoping we can continue. And then overall, I know we didn't show you much of the feedback because we're still getting pieces of those, but well, everything we're hearing from the learners right now is that the content and the format is well received. They feel like they're getting what they need and that they can participate and learn as well as they need to through what we're doing now. Doesn't mean there isn't room to tweak, but that this is a reasonable medium to try and do that. So in terms of future directions, obviously this happened pretty quickly, and so we're eternally evolving what we're doing with the curriculum. One, we're going to try and involve more learners in choosing and implementing lecture topics. Like we said before, we have a really strong belief that there needs to be kind of a theoretical, conceptual framework for what we're doing, and we're going to build a curricular arc within that. And so we want to involve the learners in that process as much as we can. We also think it's an important opportunity for our interdisciplinary learners to learn about curriculum development and how these things happen. We're obviously making more sessions as we go every day, it feels like, but regularly. And we now have enough content that we're actually scheduling out our trainees over the course of the 3 years. Oh boy. Sorry, the lights all just turned off just to add a little something. So we're scheduling out our social determinants of health activities in 3-year chunks so that we make sure that all of the learners who are there for 1 year get all the relevant content, and that all of the 3-year learners get all of the relevant content without having things duplicated, which has been helpful in terms of us thinking about what's most important and how are we prioritizing. And then finally, we're obviously going to continue to focus on feedback. We've had the most luck with our verbal feedback so far, but we're working to collect more objective outcome data. We'd like to thank the rest of our team. So we have other folks who are on our social determinants of health team, Drs. Michael Purdom and Ms. Pam Lynch, our whole COE team for all of their support in this. People have really stepped up when we've said we need, we really feel like it's relevant right now to do this session. Who's in with me on Friday? And people have really stepped up to do that with us. And obviously to all of our learners who have gone through this journey and learning opportunity with us, as we like to say. We really feel like this Lorax is on board with the way that we think about curriculum and everybody who's on this call, because we know everybody is very invested in what they're doing, or they wouldn't give up their lunch break for that. And so at that, I know we've got a few minutes left. I wanted to make sure we left time for questions. Does anybody have any questions we could answer for you?
Thank you so much. If you have any questions, can you put it in the chat box and I'll read it out loud just so it's on our video for people that are able to watch it later. It looks like there is one question from the presentation, Elizabeth. They were asking if you can share your what do your minute papers look like?
Oh, okay. I could certainly email you a copy of my minute paper, or our minute papers if that's helpful. It's typically just the 2 Likerts and then the 3 questions. I don't have one on my person, but it's actually been a validated measure. So I can send you the reference and a copy of the minute paper. Would it be okay if I send it to you, Claire, and you could send it out?
Yes. Yes.
Okay, perfect. Thank you.
Are there any other questions?
Or anybody else have any great strategies they've used for virtual learning? Because we are certainly all ears if people have ideas or things that have worked well for them.
Can we unmute and ask our question, or you'll need all the questions in the chat?
I just would like to put it in the chat so that we can read the question out loud. But if you want to ask your question, that's fine. You can do it. Unmute yourself.
Okay, thank you. Just because it takes a long time for me to use my thumbs in the chat, but thank you for your wonderful presentation. We also have a curriculum that's focused on social determinants of health. This year, with everything going on in terms of COVID and how it highlighted and exacerbated the structural inequities vis-a-vis structural racism, etc., and then kind of converging with George Floyd and basically how anti-Black racism has permeated all throughout the different sectors of society. We went through an evolution and changed our name to Health Equity and Justice in Medicine. And then because we felt that at the end of the day, social determinants of health ultimately are neutral, but and can definitely manifest itself either positively or negatively, depending on the structural drivers that inform those determinants. So ultimately, we want it to be about what the root causes, the causes of the causes. So the causes of why social determinants impact health in the way they impact health, for good or for bad, which oftentimes in an inequitable society is for worse, unfortunately. So that's why we changed our name and also changed our curriculum. And I'm so excited to see that you addressed you included or integrated advocacy, because I think that's the piece. And so when just to share one thought, really, this is more of a comment, and if you have any reflection, that would be awesome. But just to share that one of the experiences that we have teaching these topics is then learners become very overwhelmed. This is one of the major feedback of overwhelm of, oh, it's so much going on. How can I do anything about it? I can't do anything about it. And there may be this sense of moral injury and overwhelm. And so I think really integrating, number one, the advocacy piece, and number two is the community voice, and centering the community voice throughout the curriculum, and understanding that folks on the ground have first of all, living these realities. They're the ones that should be overwhelmed, not us just hearing about them. And then secondly, that they're the ones doing the work. And so if we are trying to do anything about it, we should be partnering with them. So this really, I want to invite you to kind of reflect on how, if you could share on how you center your surrounding community's voice in this curriculum, and how you connect your learners to the work that your community leaders are doing in addressing these determinants of health. I'm sorry that it went long. I was also sharing a comment. So, but thank you for your.
Well, I can say it first. Thank you for sharing that. I think I really like the way you sort of contextualized your new title for your curriculum, because I think that's a useful way for us to be able to describe why we're doing some of these things, which is really important. And I wholeheartedly agree. I find, I can speak for psychologists, we often joke that we're the worst advocates for ourselves. And then as such, often aren't great advocates for our patients either. And I think in part, I was really struck when we did the advocacy activity and talked about the op-eds, the number of people who I didn't expect who said, I've had this issue that's really been bothering me. I've been debating how I could try and address this. I felt really lost in how to be helpful. And I think they were really struck, and they were very different issues that they had been concerned about, but they were very struck with kind of that sense of helplessness. And I think, came away from it more empowered to think about how they could act on a community level here to address those issues. And so the other piece that I can speak to before my colleagues might is the other thing that I found is that we've tried really hard to add in portions to what might be a broader curriculum, specifically about Cleveland and our patient populations. So when Dr. Lightford was talking about the internet issues here, or Dr. Campbell mentioned food deserts, or those kinds of things, that we try and make them very kind of case-based and specific here so that they can understand the impact it might have on their patients, just not on people in general.
And I think when you talk about the community voice, being at the VA, I think our patients have a unique voice, and so we do often focus on VA patient-related issues and talk about the community resources and things that are being done in the community to help veterans. And so that's often a center of our curriculum. We also talk broadly about Cleveland, but because we're centered at the VA, that comes in a lot, just because veterans have a very specific worldview at times, and especially about certain situations. Hopefully that answered your question.
I'm also going to drop the link to the evaluation in the chat box too.
And did someone else type something? It flashed on our screen, but we couldn't read it.
It says, it's wonderful. Sorry, just scroll down. It's wonderful that you make the curriculum relevant to your location.
Oh, thank you. I feel like we've gotten a lot more engagement trying to do that, as opposed to kind of that enigma that is the broader context sometimes.
Any other questions?
Thank you all so much for presenting this great webinar. I think this will be referenced a lot, especially with things maybe going more virtual again. I just want to make a plug for our upcoming conference. We're accepting workshop proposals, oral and poster abstracts, and registration is open. The link is there to find more information. You could also contact me if you have any questions. And then the evaluation link is there as well. We'd appreciate you completing the evaluation.
Thank you so much for the opportunity. We really appreciated getting to talk about our curriculum, because you can tell we really enjoy chatting about it.
Well, it's great to hear. Thank you, everyone. Thank you so much.
Thank you, guys. Have a good rest of your day.
You too.